give us an update about the dual antiplatelet therapy?
So, in the field of cardiology, dual antiplatelet therapy is given mainly in two situations. One of them is the acute coronary syndrome, and the other one is when we place stents. Of course, we could have patients who come in with acute coronary syndrome and also receive stents. We could have patients with stable ischemic heart disease who also receive stents. And we could have patients with acute coronary syndromes who do not receive stents or do not go to bypass surgery. So for patients with acute coronary syndrome, they need to receive dual antiplatelet therapy. What we mean by that is aspirin therapy and a platelet receptor blocker, normally in the form of an ADP inhibitor. Of course, the effectiveness of this modality of treatment has been shown over the years. The first one with the CURE trial, which randomized people with acute coronary syndrome, unstable angina, to aspirin versus aspirin and clopidogrel, and showed benefit to dual antiplatelet therapy with aspirin and clopidogrel. And then more studies came with more medications, one of them with ticagrelor, which was from the Plato trial, that also showed benefit of ticagrelor over clopidogrel, also in the form of combination, meaning aspirin clopidogrel or aspirin ticagrelor. And aspirin ticagrelor was better than aspirin clopidogrel, both in terms of efficacy and no increase in the incidence of bleeding. And prasugrel is another modality of treatment, also an ADP inhibitor, which has also shown in this population of acute coronary syndrome patients going for PCI, which is percutaneous coronary intervention, that it has an advantage over clopidogrel, but at a slight increased risk of bleeding. And prasugrel should be used with caution in patients over the age of 75 or weight under 60 kilograms. And at the same time, it is contraindicated in stroke or transient ischemic attack. So that's why patients should be, treatment should be tailored. And as far as how long it should be, they should be treated for, usually for 1 year, but tailoring to the specific patient population, then we need to define how we go about choosing the period of time of treatment.
How and when to choose the right therapy?
So the right therapy is as follows. For example, when we have patients treated with acute coronary syndrome or when they receive stents. So as I've indicated that there is advantage to using the more recent ADP inhibitors such as ticagrelor. So that's usually better. And if we go to the European Society of Cardiology guidelines, or if we go to the ACC/AHA guidelines, actually those were released in 2016, they mention that there is an advantage in using ticagrelor or prasugrel in preference to clopidogrel. And we use clopidogrel if the patient cannot tolerate or there is reason not to use the other two. So usually it's ticagrelor or prasugrel. And in terms of duration of treatment, if the patient all of a sudden has to stop the dual antiplatelet therapy, let's say for bleeding, so then we have an algorithm from the guidelines that if the patient is on, for example, was started for stable ischemic heart disease and stent placement, then the minimum should be 3 months if the patient at high risk of bleeding. For acute coronary syndrome, usually we like to go to 1 year. If there is any bleeding problem, we could consider stopping at 6 months. But nevertheless, extending the therapy beyond 1 year is advisable if the patient is at low risk of bleeding.